Good morning, my name is Petr Wija from Prague, Charles University. I have a presentation with Dr. Iva Volnerová, who has been present but left yesterday. And the issue is situation and development in Czech Republic. We also had presentation on Monday from a colleague from Poland, who described very well the Czech system, so we'll complement. So we consider ourselves country in Middle Europe, I think in Poland, in geographical terms, maybe in some political classifications we are East Central and Eastern Europe, and you see we are in the heart of the Europe. And the Czech Republic has 10 million population, 6% foreigners. In Prague it's 13%, still much lower than Western countries. We have migration especially from Ukraine, Slovakia, and Asian countries like Vietnam, and especially Vietnam. Life expectancy is below the EU average, although we are in the Central Eastern countries the best result for life expectancy. Current situation, unemployment, it's just illustration. Spending on health is 7.4%. What is specific, we have very many very small towns and villages, 6,250 towns and villages. Some of them have only 20 people, for example. And so the importance is we have three levels of cities. The biggest role in public administration has 205 cities, which is also relevant for statistics. This administrative 205 cities have 45,000 population on average, but we have 4 cities which have about 100,000 population, and we have 14 administrative regions and 77 districts. In the past we changed the public administration from districts, but it's still used in judge system or for statistical purposes. 2% of population live in towns with less than 50,000 people. To illustrate 250 cities which have competencies in social services and other competencies bigger than the smaller kind of cities, have this map where there's this Czech Statistical Office data on life expectancy and differences, and the worst results are for the north, which was migration to heavy industry, which undergone restructuralization. There is the biggest unemployment. Also inhabitants in different kind of housing, very concentrated. So the poorest result. So we have 14 regions. One of them is Prague, which is from administrative term city. It is also region. So it is one of the 14 regions. The first one is Prague, and this is life expectancy for males. So you can see on the northwest part of Czech Republic, the region difference for life expectancy is 4 years between Prague and this. And we have also, according to OECD publication, Education at Glance, in the Central Europe is the largest difference by education. And in Czech Republic, the biggest difference between tertiary and now upper secondary education. It's especially for men, it's 11 years difference. Life expectancy at age of 30. More important is healthy life years, where there is also measured between mortality, also reported, self-reported health. And so you see Scandinavian countries, there is no such difference between genders. So it means women live longer with disability, it's clear. And yes, this is difference between Slovakia. Interesting, 10 years difference between our country, which we separated in 1993. And so The health system is financed by public health insurance. We have one big general insurance, and the other employer based, like for army and for police have insurance. Then we have home health care agencies who provide care in home, medical care, especially they employ nurses. Long-term care facilities, actually we have facilities which are called for long-term ill patients. Average stay is less than 2 months, 55 days. And the problem is that they cannot be discharged because of unavailable social services or informal care. In healthcare system, the regional authorities commission health services, and some legislation is Act on Health Services, Act on requirements, personal requirements, and so on. For example, how many people need to be in which unit, how many physiotherapists, how many geriatricians. And in 2008 we had a big revolution. We introduced first out-of-pocket payment that you had to pay 30 crowns, which is slightly above €1. And it was really hard to accept for majority of population. The result was that the soonest election was regional elections, and they were all blue, which is right-wing, and they turned first in the history of this election all to the orange, which is Social Democrats. Yes. So it's very. They introduced in hospitals machines that you had to put coins or to send SMS to pay for the visit. In ambulance, it's 30 crowns, and for 100 crowns for 1 day in hospital. And at the pharmacy for your prescription, you pay 30 crowns. But the pharmacists say you don't have to pay here because they want to attract people. But there was also constitution, the Social Democrats, that it's unconstitutional, that healthcare should be free and available for everyone. Now the charge in hospital because Social Democrats won the election was cancelled. And even then the Social Democrats won that they promised people that they will repay them the money they paid for the hospital stay. But even though there were limits, 1 year limits for maximum payment you could pay to your health care. In social care system we have new Social Services Act, which also colleague Pavel Ručák spoke about. And it was major reform because it introduced inspections of quality, standards of quality, and especially it introduced new social benefit, cash benefit called care allowance in 4 degrees. So it very rapidly increased the social expenditure, 20 milliard crowns per year. It's per year the cost of paying this benefit. And 2/3 of the recipients are aged older than, it's a medical assistant service, so medical doctors assess it, and also plus social worker visiting home and should evaluate what you are able to do. But they ask person, for example, with dementia, what you are to do, and they say, I'm able to do everything, you know. It's not good for informal carers. And the problem is that 3/4 of this go to the informal care, because people can choose how to use their money, and of course they keep it in the family. So they are considering to introduce vouchers, but if you introduce one social benefit, you cannot cancel it easily, you know. Too many now. It's I don't know. It was very wise because we wanted to have more social services, especially home, and it was disability groups lobby. They wanted to have like agreements and formal agreements and to choose, but it didn't help develop more services. Also because very small municipalities we have, and so it's financed by state budget, and people also pay for in senior homes. So this is it covers only 3% of total population, 300,000 people, but in population of 85 plus, every second person has this. So it's like seniors allowance, and it's, in long-term care, we don't have a long-term care scheme. And there was 2 years ago the proposal already for a Long-Term Care Act, which has not been adopted by Legislative Council. They say you don't need to make new act. You have Act on Social Services and Act on Health Services. Change both these laws, and you don't need to have new act. And it finished. It was just discussion. I don't know, it wasn't very effective. So nothing changed really. They said just say, okay, we will come back and work on the specific norms. And the situation is that we have nursing units in seniors' homes and in homes with people with dementia, where were nurses who have special qualification called nurse in social care facility. And but the healthcare companies then want to contract with them. So it's a big division, and the health status of them is becoming worse and worse. More than half have dementia, and other conditions are bed-bound. So it's practically like social hospitals. It's become part of health system, but not directly covered by health system. So this is unequal, because you don't have to pay large money, and you don't have equal access as in long-term care institution for persons. So very, very unequal. As I said, these are districts, 77 districts, and if we compare the number of places in senior home per population, it's very, very diverse regionally. There are many factors for these differences.
Could you say what does the average come out on there? Because it's difficult to...
Average? I don't know. I can say maximum, for example, in region or this is
the last column, the Czech Republic.
Yeah.
Yes, you are right. Czech Republic. Yes. So it's 100 nearly.
It's 100 per 100,000.
Yes.
So it's 1 in 1,000.
Yes. I think it's many, or okay, we will then discuss. I will skip. And I colleague to keep me if I'm on time, because I have to control myself. So long-term care system, we have health services and social services with different registration criteria, different quality standards, different personal requirements. Actually, social care facilities don't have personal requirements, such as health facilities. For example, to employ a physiotherapist or geriatrician, or but there are requirements for long-term health care in law. That doesn't apply to people in nursing units in social facilities. So it's very problematic. And different payments. Of course, people want to have their relative in healthcare facility because they don't pay nothing. And now even they cancel the 100 crowns per day. These institutions reported we have sharp increase and pressure to have their relatives in our facilities. Different system of financing. We have insurance and then state budgets. The definition of target group is not very precise, so it means it's uneven quality and accessibility regionally, and also in terms of payment and quality. So, and more people are dying in social care institutions. It's quite rapid, slow rise, especially women. And so we have access to health services, but to social services, there is access to care allowance, but it doesn't mean you get care allowance. You have from your municipality right to get, for example, adaptation of your home or emergency service or anything like this. We have like home social care, but it's often only delivering food. And in local government act, for example, Sweden has Social Services Act where they specify the role of municipalities concretely, but in Czech legislation it's a very general and not like on voluntary basis that if they don't have services, so they say, oh, it's our tradition, we take care of each other. Pardon. So it's in line with the tradition. It's in accordance with the law because they say they don't have need for such services. So the problem is access to some services. Resortism, which is specific. I don't know if Czech. In France, it was compartmentalism, or how do you call it? We have Ministry of Health and Ministry of Social Affairs, and they establish every 2 years a commission for long-term care. It's since 1990s, and it seems that it's not possible to find some solution, some agreement, because they keep their own budgets. Finally, they say it's social and it must be from your pocket, and the others it's healthcare, it must go from your budget. So the other problem is the position of resources from municipalities. They have some money from state budget, from taxes, but they are not earmarked like for social services or something. So the problem is that many social services are provided by NGOs who have to apply for subsidies and write administrative applications, which is time-consuming, and they don't know if in 2 years they will have money for their service. So it's different than insurance system, which is more stable, I think. So, and also we don't have comparable data on or transparent data on of impact of care or quality of care. We have yes, we don't have migrant workers in our health system, but we have migrant workers, for example, in hospitals from Ukraine, especially. But we will see how it will be in the future. And the problem is the effectivity of the system as a whole, societal costs. So we always say the Ministry of Finance should come between Ministry of Social Affairs and Ministry of Health as a because it's all collected public money for health insurance. It's paid by employers and employees and taxes. So the impact should be for all. So accessibility improved, but the law didn't meet the expectation to support especially home care services. And the tendency is that income and regional disparity are growing in terms of economic performance and income performance between Prague and other parts of regions. It may also cause other regional variation in quality, and also working conditions in health and social care sector are different, which is nurse in social sector is paid less than nurse paid in a long-term institution for under Ministry of Health or under health system. So, and there's also increasing discussion about private role, but as was discussed, it's absolutely no choice, because if it would be voluntary, nobody nearly would join this insurance. But we were contacted by insurance companies that they want to do marketing to have such. So for some small group it will be, but potentially it can also increase, of course, differences in quality. And so thank you very much.